Well, what about Pembro? FDA approved. Are you excited about it? Do you feel like it's doing something for the sake of doing something when the patient comes back with pneumonitis and colitis and their fingers have, autoimmuned off? Are you like, I helped you?
So I think it needs to be discussed with every patient because it is, besides valrubicin, which isn't really that readily available. It is the only FDA approved drug. I think, at least in my practice, it always comes up in a discussion, mostly as an option. But because we have the availability to enroll on clinical trials with a component that has intravesical gemcitabine, I do send my patients with BCG unresponsive disease to meet with the medical oncologist, and they'll discuss pembrolizumab as a monotherapy. Very rarely does a patient actually opt to go on that, but it's more for the discussion of pembrolizumab within the context of a clinical trial, or any immune checkpoint inhibitor within the context of a clinical trial. But I think, the data isn't very compelling. It's great that it was FDA approved, but, it's a 40% response rate at 3 months. And, beyond 12, 18 months or so, only about 20% of patients remain disease free. So I have a slide with a table on it that basically has like the expected response rates for the various options that are available to patients. And, most patients, or many patients, will even decline meeting with the medical oncologist because neither one of us is very enthused about the potential results with pembro as a monotherapy.
Yeah, I always thought our medical oncologists are not very eager to be giving pembrolizumab to a lot of these patients as well for the associated toxicities. And they're actually pretty strict about it too. The FDA approval was only in the Keynote 057 publication that's thus far been published has only been in CIS disease, with or without papillary disease, concomitant papillary disease. So they're pretty strict about which patients they would even consider giving pembrolizumab to, because of the fact that only about 20% had that clinical response or complete response beyond 12 months. So it doesn't even really meet some of the prior goals of the FDA as far as complete responses at 12 months.
I think there would be a little bit more enthusiasm if there was a biomarker-driven approach to this. I think the unselected patients, not the risk-benefit trade-offs between these immune-related adverse events and the sort of marginal benefit that patients receive. I think, the math, unfortunately, isn't in the favor of treating many of these patients. But if there was a biomarker to select these patients, I think that would definitely be very beneficial. But unfortunately, in the publication, PD-1, PD-L1 staining wasn't beneficial, wasn't helpful. So hopefully there is some work ongoing from the result from the Keynote 057 cohort, and other work is ongoing. But until that happens, I think there's going to be a lack of enthusiasm, as a urology community, at least.
Yeah, and I think you're absolutely right. I mean, at this point, I'll typically start looking into things like tumor sequencing when I'm getting worried. And, we can certainly envision a day where altered patients would go on to something like erdafitinib. And, it's exciting, right? It's exciting that over the course of our careers, and we're not like 1,000 years old, we've seen kind of these new changes, new options. I mean, I remember being at like a dinner during residence with the Valstar people and just being like, oh my gosh, like I wouldn't even offer this. It's so,
Right.
disappointing, like a 10% response rate. And, at least we have some other options now.